modified it as hematology and bone marrow transplant. I hope I'm audible. Is my voice okay?
Yes, sir, your voice is audible.
Yeah, thank you. So when it comes to hematology, and then the advanced portion of hematology is bone marrow transplant, and it's a teamwork. It's not just hematologists, all clinicians, pediatricians, physicians, and the hematologists together handle all these cases, and it's a battle which is together fought better. So we have a lot of time in the current COVID pandemic, and a lot of online platforms give us access to many movies. I will strongly like to recommend a few of the movies. There are quite a number of movies on hematological issues as well as bone marrow transplant. One of them is My Sister's Keeper, a journey of two sisters who one of whom is suffering with the blood cancer, and the other turns out to be her donors, bone marrow or stem cell donor. It is based on a wonderful novel, Marrow by Elizabeth Lesser, one of the best-selling authors from the US. And not only in the Hollywood, in Bollywood also we have quite a few movies addressing various aspects of stem cell transplant, particularly the bone marrow transplant. So one of them interesting is Sky is Pink. Basically, a girl born with a primary immunodeficiency disorder undergoes bone marrow transplant, gets cured of her disease, but subsequently gets the after effects of the chemotherapy which was utilized for her bone marrow transplant, and that is busulfan. So, the whole issue revolves around her lung toxicity, pulmonary fibrosis, and there are many such, this kind of, I'm sure there are many of us in the audience who love movies, and this is the best time to enjoy movies. And before I start my talk, I would like to thank all of you for sparing your time amidst the busy schedule handling the COVID pandemic across your hospital. And this talk is dedicated to many of our colleagues who have lost their lives in the battle against the COVID across the country. To the best of our knowledge, we have lost more than 150, the true warriors, the medicos fighting the COVID for the society. I had no conflict of interest, and we are really thankful to Get Well Oncology for sponsoring today's wonderful academic session. So before I start my talk, I'm even though my education has not been related to Solapur, but I am way related to Dr. Vaishampayan Memorial Government Medical College Solapur by two of my eminent and my close friends. One of them is Dr. Gaurav Kharia. He's a MBBS alumni of Vaishampayan Medical College 95 batch. He's one of the leading pediatric hematologists, and he's the director of bone marrow transplant unit at Indraprastha Apollo Delhi. One of the dynamic pediatric transplanter in our country, and he is savior for most of my pediatric hematology and pediatric bone marrow transplants, which I will share in subsequent discussion. I owe him a lot, and whatever pediatric work I am able to do, a lot of my credit goes to one of your colleague from Solapur, Dr. Gaurav. And the other colleague is Dr. Rayaz Ahmad, again, who did his MD from Solapur, VMGMC, and he is an adult hematologist and a transplanter, currently a senior consultant at Rajiv Gandhi Cancer Institute, Delhi. And lot of my problem adult cases, he is my savior in difficult times. It's kind of phone a friend, and he is the one who always comes to rescue in the challenging and difficult times. So in a way, I'm part of VGMC Solapur. So before I start my talk, let us start with a case, real life scenario, which will, for us students during our MBBS clinical case scenarios, makes things more understandable and Interesting. So this is a 9-year girl, class 4 student, presents to me with symptomatic transfusion-dependent pancytopenia. So she presented in the year 2016, and she also had fever, mucocutaneous bleeding, and she has visited multiple hospitals with severe pancytopenia. When she was hospitalized at our place, she had severe pancytopenia, WBC less than 1,000, and blood culture, to our nightmare, turned out to be multi-drug resistant E. coli positive. It has grown MDR E. coli. And I'm sure most of the students in the final years, you must be knowing the importance, the current threat to the mankind, apart from the COVID crisis, which is a pandemic going on, but then overall, due to the rampant indiscriminate use of antibiotics, the multi-drug resistant bugs are killing a lot of even younger, healthier patients. So this is her summary. December 2016, symptomatic pancytopenia, anemia, leukopenia-related infections, upper respiratory tract infection, and thrombocytopenia associated bleeding. And this was a hemogram. You can see she has severe pancytopenia, hemoglobin just 6 grams, WBC 300, platelet 10,000, and LDH was normal. This was her peripheral smear. A lot of us during our pathology training, peripheral smear, bone marrow, we might have seen, might have chance to, this is a therapeutic window for all hematological cases. So just like ECG for a cardiologist, endoscopist for a gastroenterologist, and various imagings like CT, MRI for neurologist, interpretation of hemogram is an important tool for dealing with most of the hematological cases or hematological diseases. In fact, if I am not overstating, if you learn the art of reading hemogram, I guess 95% of hematological cases you can come to a reasonable diagnostic conclusion. And by meaning hemogram, I just don't mean the values, the numerical values, hemoglobin, WBC, platelet, blast present or not, cancer cells present or not, but also these histograms. Reading hemogram is an art, and I'm sure all of you who can master the art of reading most difficult ECG, which I was never able to, master compared to my other colleagues, then reading hemogram, definitely you can master, provided you give little bit of time to learn this hemogram reading. So then based on her severe pancytopenia, we did bone marrow, and bone marrow was like this. The upper picture is bone marrow biopsy, which is just empty bone marrow biopsy filled with fat spaces. You can see the pinkish one is the bony trabecula, and in between, normally for a young girl like her, the cellularity, bone marrow cellularity, there is a simple formula. The bone marrow cellularity is inversely proportional to age. So children have a highest cellular bone marrow, and elderly population have lesser cellular bone marrow. So she is considering 9 years old, her bone marrow should be at least 90% cellular. And what you are seeing on the bone marrow slide is more than 90%, it is filled with fat spaces. So it's an empty marrow called as hypoplastic marrow. And when a child presents with such severe hypoplastic marrow, we have to decide whether it is inherited bone marrow failure disease or acquired. And for that, we do something called as stress cytogenetics. If it is inherited bone marrow failure, on stress cytogenetics, you will see spontaneous or mitomycin-induced chromosomal breaks, which was negative. So this is an acquired aplastic anemia. So the diagnosis is severe aplastic anemia, acquired. Now, how are we going to treat this case? I will like to remind you, her WBC count is 300, neutrophils less than 100. She had MDR E. coli on the blood culture. She is spiking 100, 405 fever, platelet 10,000, hemoglobin 6. This is the most common scenario we see in our practice. And you might have experienced aplastic anemia is a medical emergency. Most of the patients die if we don't deal them aggressively in a timely manner. So idiopathic severe aplastic anemia, this was her blood culture plate showing these shiny E. coli colonies, and you can see on the sensitivity pattern, you might have seen in your microbiology posting when there is an antibiotic impregnation on these culture plates. If there is a halo around that antibiotic impregnation, that means that antibiotic is sensitive. Whereas You can see on this plate, most of the antibiotics are resistant. Only the one at 12 o'clock position, that is colistin, she was sensitive only to colistin. So this is a multi-drug resistant infection. Now, how did we manage her? You can see December 2016 was her presentation, neutrophil count 80. This is a dying patient. In fact, I would like to tell you that she has visited esteemed centers across the country, north, south, east, west. Single daughter of the family, parents wanted to save her at any cost, and they approached the premier institutes because of her severe pancytopenia. Aplastic anemia, this is a common scenario, but a multi-drug resistant infection made most of the institutes to defer aggressive upfront therapy for her, and that's why she ended up with us. So what we did a HLA gene testing from the father and mother. Mother, father, as you know, both were HLA half match, and that's how we inherit HLA genes. I will come to that in my subsequent slides. And because this is a medical emergency, we decided to go ahead with half match bone marrow transplant with father as a donor. And this was the chemotherapy given to destroy her defective marrow. Unfortunately, you can see even after 1 month of intensive care, WBC around 50 to 100, neutrophils almost zero, continuous persistent pancytopenia, repeat bone marrow empty. What does this mean? 1 month of transplant, her marrow is completely empty. That means she has rejected the stem cells from the father. Now, the diagnosis here is a bone marrow transplant. First bone marrow transplant failed, which was half mass transplant with father as a donor. Now, this is a deadly condition. If we don't try to rescue her with subsequent available option, she is anyway going to die. And even if you try the best possible subsequent therapeutic option, the chances of success is in the figure of 10 to 20%, because longer the duration of neutropenia, higher the mortality. So we immediately quickly decided to go ahead with second transplant. We switched the donor from father to mother, and we did the second transplant. And before we go to the details of transplant, in half match bone marrow transplant, one of the common, the half match bone marrow transplant is very challenging, comes with a lot of complications, lot of risk. But one of the common risk is graft rejection, because the donor is half mismatched with the patient. So roughly the risk is around 10%, and unfortunately our girl has felt in that 10% risk, and she has rejected her father's stem cell. So we immediately did second bone marrow transplant. This time we succeeded. You can see her counts have persistently normalized. She's doing extremely well. But again, transplant is not a simple 1 month affair. After the transplant, a lot of complications continues to happen for next couple of years. So after 6 months of transplant, she developed opportunistic infections like viral reactivation, cytomegalovirus reactivation, graft versus host disease involving skin and gut, and which is again a problem with most of the transplant. The risk of graft versus host disease is higher in half mass transplant. I will explain you what is graft versus host disease, what are opportunistic infections. So we'll just proceed with this case. We managed with various available treatments, like CMV was treated with ganciclovir and antiviral drug, and the graft versus host disease was managed with steroids and various other immunosuppressants, which was resolved. Now you can see June 2018, normal. Again, last visit this year, normal. So you can understand and guess, and you can guess that a girl who was almost moribund, almost dying, her odds of her coming out alive with this deadly disease with resistant infection on board at diagnosis was less than 10%. And because of the timely bone marrow transplant, she is alive more than 4 years. And I will say she is cured of her deadly aplastic anemia, which is a very life-threatening bone marrow failure disease. So a change in our mindset to get a chance of cure is very, very important. And this is apt for most of the hematological conditions. And moreover, particularly the pediatric hematological disorders have a very rewarding outcomes with success exceeding 80-90% in most of the cases. Now, changing gears further, so the outline of my talk, is all the basics about bone marrow transplant. What is bone marrow transplant? Who needs, where and when it is done? How many types of transplants, and why we need to know about bone marrow transplant at our undergraduate level. So, what is the aim of bone marrow transplant? And mind you, I'm talking of hematopoietic stem cell or bone marrow transplant, which is almost same, but not stem cell, experimental stem cell therapy for other systemic disorders, neurological or other disorders. You might have heard of stem cell therapy as an experimental therapy in other disorders, but my talk is only on hematopoietic stem cell transplant for hematological conditions, which is approved across the globe. Now, for malignant or the cancerous conditions, the aim of transplant is to permit very high dose chemotherapy, because the cancer has a dose response curve. Higher the dose of chemotherapy, the more is the cancer kill and more the chances of disease getting complete control. And the second effect is these stem cells in allogenic transplant can exhibit something called as graft versus leukemia. So the stem cells from the donor, they continue to attack the remaining cancer cells and thereby preventing the cancer coming back. And this is the curve you can see. This is the famous Gaussian curve, Gomper's law, wherein you can see the dose of the chemo is proportional to the cancer kill or tumor control. Higher the dose, higher the cancer control. But then when the chemotherapy dose goes very high, the bone marrow gets irreversibly damaged. So without stem cell, you cannot recover the bone marrow, and then that is the rationale for bone marrow transplant. And for non-malignant or non-cancerous disorders, to restore normal hematopoiesis or replace defective genes. So you have to think differently, particularly in a specialty like hematology. So, the rationale, as I mentioned earlier, replacement of defective marrow stem cells for the normal functioning from a healthy donor. So, for example, immunodeficiency disorders called as severe combined immunodeficiency, the lymphocytes are defective. And you can see this is the famous bubble boy, one of the famous patients in 1970s. His name was David Vetter. He survived up to 14 years. Prior to this fellow, most of the children with severe combined immunodeficiency, they are so immunocompromised, they die within first 1 or 2 years of life. So with huge efforts, they made him alive for 14 years. And how was he? So bubble boy, in a bubble, chamber, even when he's outdoors, they used to put bubble around him with positive pressure, sterile air to protect him from the environmental infections. And that's how he survived. So, whereas in other disorders like beta thalassemia, the erythroid cells are defective. And you can see a boy with beta thalassemia can present like this because of extensive marrow expansion, because whatever red blood cells are produced, they are defective. They die within few days. Normal red blood cell lifespan is 100 to 120 days. In thalassemia, it is hardly 5-10 days. And that's why these patients require lifelong blood transfusion. And with blood transfusion comes other, complications, toxicities, iron overload, damaging each and every organ in the body. And then in these patients, bone marrow transplant can completely replace the complete bone marrow and can cure the thalassemia patients. Other immunodeficiency disorders like chronic granulomatous disease, Chediak-Higashi syndrome, where myeloid cells are defective. Again, you can see a boy with Chediak-Higashi disease, gray hairs, silver hair, silver eyebrows, and hypopigmented patches and immunodeficiency because of defective myeloid cells. Again, can be cured completely with allogenic bone marrow transplant. And again, as we has just seen the previous case, aplastic anemia, where all the hematopoietic lineages, erythroid, myeloid, and platelet cell is defective, the bone marrow transplant can completely cure. And this is the picture. On the left is the aplastic marrow, and on the right, for the sake of understanding, I had put the normal marrow. How does a normal marrow looks like? Completely cellular. Whereas the left side marrow is completely filled with fat cells, and this can be cured with timely bone marrow transplant. Now, apart from that, for malignancies, for cancerous conditions, the aim of rationale for transplant is mostly the autologous or allogenic both. So rescue the marrow from very high dose chemotherapy or chemo plus radiotherapy, as well as graft versus tumor effect. Like for example, for acute myeloid leukemia, usually in first disease control, we do bone marrow transplant in high risk, and we might all of you must be knowing that the actor, famous actor Rishi Kapoor has AML, and he underwent bone marrow transplant in US, and unfortunately he could not sustain the disease control, and recently he lost his life. Again, in acute lymphoblastic leukemia, the results with chemotherapy alone are very good. Cure rate is more than 80-90%. So transplant is given when the disease comes back, right? So in other cancers like CML, accelerated phase, and we all know that the bone marrow transplant in CML is far less compared to what we used to do before 2002, 2004, because we have a wonder drug, magic bullets. You can see the Times magazine having a special issue on these magic bullets on bone marrow, for this deadly blood cancer. Again, lymphoma, myeloma, you see autologous transplant. This is the famous actress Lisa Ray, who has undergone autologous stem cell transplant in the year 2009. This is a recent shoot about a year ago. You can see even after 10 years of transplant, she's completely normal, with the timely bone marrow transplant. And then again, pediatric, some solid cancers like neuroblastoma, which have a very poor prognosis, and autologous transplant can cure some of these cases. The third rationale is inborn errors of metabolism, mostly the genetic disorders, where because of the defective genes, there is tissue damage because of the toxic metabolites which are not metabolized correctly. You can see in this figure the macrophages. And then here the donor tissue histiocytes, they remove these toxic metabolites and they reverse the organ damage. Also, the defective enzymes or genes are replaced by healthy donor stem cells. So normally the hematopoietic stem cells, the reason why we coin both bone marrow transplant as well as hematopoietic stem cell transplant, when the source of stem cell is from the marrow. So before 1990, most of the transplants were from the bone marrow as a stem cell source. So what are the stem cells? They're identified by two markers, CD34 and CD45. So this is bone marrow harvest. But nowadays, most of the transplants we do with peripheral blood stem cells. So the patient's peripheral blood stem cells are collected on apheresis machine, just like we collect platelets, we collect stem cells without doing the painful, risky bone marrow procedure. And sometimes we use umbilical cord blood stem cells for select cases. So the dictum is we should know the basics of bone marrow transplant. So like the famous saying by Albert Einstein, if you can't explain it simply, you don't understand well enough. We need to understand the rationale for bone marrow transplant to understand about bone marrow transplant. So now evolution of modern bone marrow transplant. Bone marrow transplant is a newest kind of transplant. The history is not very old. It's about 70, 80 years history in the era of bone marrow transplant. This is how bone marrow has evolved. You can see the first breakthrough for bone marrow transplant was through discovery of HLA antigens by Dr. Jean Dowsett, who is a French biologist in 1958. Subsequently, the first bone marrow transplant was done by Dr. Georges Mathe from France, 1960, for few Yugoslavian scientists who had accidental exposure to deadly radiation, and many of them were salvaged, survived with transplant. And in the same year, Peter Medawar, a British biologist, discovered transplant immunology, the SLA, and the tolerance, how the donor stem cells are accepted in the patient's body. So immune tolerance, and he got Nobel Prize for his discovery in the field of transplant immunology. And subsequently, 1968, Van Rood and for modern HLA typing, they discovered, and the major breakthrough came in 1971 when Professor Donald Thomas from Seattle, USA, where I also had an opportunity to have a short-term training, got Nobel for his immense work in the field of bone marrow transplant for blood cancers. So in fact, he published in 1974 first 100 patients who used to die prior to transplant. The mortality was more than 95%. With transplant, about 40% were surviving long. Subsequently, again, another colleague of Professor Donald Thomas, John Hansen, in 1979 did in the first unrelated donor transplant again at Seattle in Washington, USA. Subsequently, the first umbilical cord blood stem cell transplant was done in 1988 by Professor Dr. Broxemeyer and Dr. Boyce from USA. So we just discussed about Nobel. It's an interesting fact. What is Nobel and who is Alfred Nobel and why do we give Nobel and why is Nobel so prestigious? So last year I had an opportunity prior to this COVID pandemic to visit the city house in Sweden, where the Nobel is distributed. So Alfred Nobel was a great businessman and who was the one who first discovered dynamite. And a lot of criticism against him for all the the lethal weapons which he discovered and which was his business. So he has decided to do something of a noble cause, and he started Nobel Prize, which is bestowed in several categories by Swedish and Norwegian institutions in recognition of academic, cultural, and scientific advances. So this was established in 1895, and in the field of hematology, there are 5 Nobel till now. So the first one was for the discovery of human blood groups Karl Landsteiner in 1930. Again, pernicious anemia, liver therapy in 1934, William Murphy and George Whipple. That time, loads of liver used to be given to the patient suffering with megaloblastic pernicious anemia. Now we have a simple B12 injections, just 1 cc injection can cure or get adequate dose of B12. But that time, even with such a little weird therapy, but that was in 1934. 1984, Dr. Caesar Milestone and George Kohler received Nobel for their discovery of monoclonal antibodies. And nowadays, monoclonal antibodies are everywhere. You might be hearing about tocilizumab IL-6 antibody, which is also a monoclonal antibody. The root was here. Again, the father of modern bone marrow transplant, Professor Donald Thomas from Seattle, Washington, got Nobel in 1990. And recently, James Allison and Tasuko Honjogo from Japan for immuno-oncology in 2018. So, out of 198 Nobel in medicine, 96 used animals, 12 did not use animals. Coming to Nobel, one of the eminent Indian scientists who deserved more than Nobel, but unfortunately, due to racial disparity, could not get Nobel during his times, 1950s, is a Telugu man, Professor Yallapagrada Subbarao. Miracle man of medicine is what people label him across the globe. And he has immense discoveries to his credit. He was the first one to discover folic acid, and first anti-cancer drug, methotrexate, was synthesized by him in USA. Unfortunately, a lot of people who worked with him, like Sidney Farber, Benjamin Duggar, and George Hitchings, got Nobel, but he, who was the most deserving candidate, didn't got. But eventually, after post his death, the world famous Times magazine has issued a special article in his memory, and also Indian government has felicitated by issuing a postal ticket against on his memory. His wonderful journey can come across through a very illustrative, encouraging book, Wizard of Wonder Drugs by National Institute of Nutrition. I'll strongly recommend students to, if possible, if you have time, to go through this book. It's a very, very enlightening book amidst leisure time, which is happening now. So again, the Indian Nobel, the Padma Shri. 2019 was a very fruitful year for the field of hematology. 2 of the eminent hematologists, one of whom is my teacher, father of hematology, bone marrow transplant in India, Professor Maman Chandi, was felicitated with Padma Shri. And another fellow from our Maharashtra, Mr. Sudham Kate, Dr. Sudham Kate, for his extensive work in the field of sickle cell disease in rural India. So the common misconceptions about bone marrow transplant many of us clinicians feel bone marrow transplant is a major surgery like other solid organ transplant like liver, kidney. It's not a surgery. It's a simple stem cell transfusion, which I mentioned earlier, but it comes with a lot of intricacies, and that's why we need a dedicated bone marrow transplant unit and a specialized bone marrow transplant physician. Blood group matching is essential for bone marrow transplant. That's wrong. What is essential is some genes called as human leukocyte antigen gene matching is essential. And with the advent of science, we don't need full match all the time. Even if we have half match donors, sometimes that suffice if the condition of the patient demands immediate urgent bone marrow transplant. It, many of us believe that donors have a risk to donate stem cells or bone marrow. It is not at all risky. Just like platelet donation, stem cell donation is also equally safe. And most important for most of the clinicians, they feel that bone marrow transplant is the last step in the management in hematological disorders with dismal outcomes. It's not true. In fact, it is only light at the end of this suffering tunnel of most of the hematological diseases and blood cancers with cure rate exceeding 80%. So the famous saying, eyes are useless when the mind is blind. Unless and until we think of these aspects, we won't be able to refer or get these patients on track for available therapies. Now switching my gears further, as I mentioned earlier, transplant is not a surgery, it's a simple stem cell infusion with a lot of intricacies. Now, there are different types of bone marrow transplant. Autologous, when patients' own stem cells are used and mostly used for blood cancers like lymphoma and myeloma. Syngeneic, where genetically identical to which accounts for less than 1% of transplant. Allogenic, where HLA gene matched or partially mismatched or matched donors. So if it can be HLA identical, 100% HLA identically matched sibling, it can be matched unrelated full HLA matched donor from the international registry, that is called as matched unrelated donor, MUD. Mismatch, which we just witnessed in our first case, that is haploidentical half match donors. Now, how do we find a donor? Now we all know, the HLA genes follow the Mendelian inheritance, just like autosomal recessive inheritance. Whatever HLA genes we have, half of them we have inherited from our father and half of them from our mother. So, the probability of all the children, there is 25% chance that two siblings can be matched with each other. And that's why when there is only 25% chance, and as the number of siblings increases, the number of match increases. And that's why we need to look at international donors or international registries to find a donor when we don't have a family donor. So as I mentioned earlier, so in any case, the 100% match possibility among siblings is 25%, 50% will be half match, and 25% will be complete mismatch. Whereas parents are always half match with their offsprings. So the algorithm for donor search, previously we used to use only matched sibling donors. We used to defer transplant if we don't have a fully gene matched, HLA gene matched brother or sister in the family. But nowadays, because of the advancements of the medicine in the field of transplant, hematopoietic stem cell transplant, and having the results of half match transplant almost equal to matched sibling transplants in many of the indications or conditions, any donor available is enough to go ahead with transplant. So why do we need a bone marrow transplant unit? As I mentioned earlier, to get rid of the defective bone marrow, we need to destroy that defective bone marrow with high dose chemotherapy. And when we give this high dose chemotherapy, patients' blood count falls to almost zero. Hemoglobin, WBC platelet. The most dangerous is the white blood cells. The patients, because of the severe neutropenia, patients will be at risk of various infections. And that's why you need this dedicated bone marrow transplant unit where everything is maintained meticulously clean in a positive pressure room. The patients are so sick because of the chemotherapy, because of the severe cytopenias, and you can see what we see in the bone marrow transplant room is that portable monitor, as well as various infusion pumps, and the nurse or the staff caring for such sick patients around the clock. And that's how we handle these patients under strict aseptic, sterile conditions in the bone marrow transplant unit. And not only that, these bone marrow transplant units are kind of special ICU which are fitted with special ACs called as HEPA filters, high efficiency particulate air, where air particles of size less than zero point 0.2 microns or zero point 0.3 microns are allowed to enter the room. Divide this air is divide of all pathogenic bacteria, fungi, viruses, because most of them are above the size of zero point 0.3 microns. And this is how the unit looks like: sterile, clean. Everybody entering the unit changes their dress, scrubs suit, just like operation theater. Everything is maintained meticulously. The housekeeping keeps on cleaning these rooms twice a day, surface cleaning. Uh, Hand wash is an integral part, and the aseptic precautions are immense important to save these patients. And uh, everything is handled very carefully. Even the not only the drinking water, but the water for sanitary purpose is fitted with this point 2 micron filters to avoid waterborne infections. And medicines are prepared under strict aseptic conditions. The food is served hot. In fact, the cooker is open at the patient bedside to ensure food sterility. And that's how we do the transplant. So what are the transplant process? So as I mentioned earlier, to get rid of the defective bone marrow, we give conditioning chemotherapy, which eliminates diseased marrow and also prevents the graft rejection by the patient, usually administered over 6 to 7 days. And at the same time, for allogenic transplant, the donor gets injections to mobilize stem cells from the marrow to blood. This is called as GCSF, granulocyte colony stimulating factors. Normally, the stem cells reside in the bone marrow. By this injection, the stem cells are made to get released from the marrow and come to the blood. The next step is stem cell collection from the donor and infusion to the patient, and which is usually this day is called as day zero, an infused IV, just like any blood transfusion, right? And then next step is the pre-engraftment period, that is usually less than day 30. I'm sorry, it's a typographical error. It is around day 30. So before the stem cell generate a new blood system. So this time is managed by keeping the patient in the sterile bone marrow transplant unit for profound cytopenias, intense barrier nursing to avoid infections. Then comes the major time, post-engraftment period, which ranges from 3 months for 3 to 6 months to autologous transplant, and allogenic transplant 6 months to 2 years, because during which period the patient is kept under periodic follow-up because of the normally the immunity. You can see from this curve. I'm sorry for this busy slide, but you can see the neutropenia phase is up to day 30. But then after the neutrophils recover, that is called as engraftment, immunity doesn't completely recover. You can see the lowest portion on this slide. You can see the green B cells and the violet T cells. The recovery takes 6 months to 6 to 12 months, and that's why they are still immunocompromised, and that's why they get various infections, bacterial infections, viral infections, fungal infections. Apart from that, the stem cells can attack also the patient's body, called as graft versus host disease. If it happens below 100 days, it is called as acute graft versus host disease. If it happens above 100 days, it is called as chronic graft versus host disease, and you need to monitor and treat accordingly. And these are the graft versus host disease manifestations: skin, liver, gut, the skin rash, jaundice, gut, any organ can be involved, but for acute, these are the three common organs. And for chronic graft versus host disease is something like you might have seen in your medicine posting, the various chronic autoimmune disorders like SLE, scleroderma, systemic sclerosis, the fibrosing skin lesions or organ lesions leading to various problems. And apart from that, organ dysfunction because of the chemotherapy, various drugs, and also for blood cancer, there is always a threat of disease coming back, and that need to be monitored. So bone marrow transplant cure rates are 70 to 80% or 80 to 90% depending upon the type of the blood cancer, but still there is 10-20% chance that disease might come back. So at the end of this rigorous exercise, what you end up is like this. This is our first aplastic anemia transplant. A dying patient, almost zero neutrophils, having a invasive fungal infections completely eroding his left eye. You can see the left eye proptosis and swelling, redness. And 10 months post transplant, because of the invasive fungal infection, we needed to remove enucleate his left eye, and the left eye is the artificial eye, and this is 10 months post transplant, completely cured of his deadly disease. These are the indications of transplant, most of which I had mentioned earlier. Not only blood cancer, but non-cancerous conditions like bone marrow failure, aplastic anemia, uncontrolled autoimmune disease, various genetic disorders like primary immunodeficiency disorders, genetic storage disorders, hemoglobinopathies like thalassemia, sickle cell anemia, inherited marrow failure disorders. The list is endless. these can be completely cured with bone marrow transplant. A role of transplant in blood cancers, the compared to chemotherapy, the chances of cure are doubled with various transplant options, and that's why we do transplant in blood cancers. So, like the famous Telugu saying or the Telugu suspense 3 years back, which fetched the highest revenue to this movie, Bahubali 1, 2, why Katappa killed Bahubali. Like that, this kind of, the curiosity, integrity is important for medical students. The more why we ask ourselves, the more wise we become. So coming to our achievements at Yashoda Hospital, Hyderabad, what is new? So we launched our bone marrow transplant unit in 2015, and we had the privilege of my teacher on the right side. Besides me is Dr. Maman Chandy, the father of hematology in India. He is the celebrity here for BMT unit launch. And these are the results. This was our first half-mass transplant way back in 2015. Multiply relapsed AML, still doing well. This was the youngest patient I did transplant, 9 months, severe aplastic anemia. You can see the baby sitting on mother's lap. This is 6 months post transplant, completely cured. This is again African patient, sickle cell disease. The 3-year girl was transplanted from stem cells from her 8-month donor. We harvested bone marrow from 8-month donor, and that was cured. This is one of the world's rarest of transplant. Viscott-Aldrich children, 2 brothers, having both were misdiagnosed as ITP, even thrombocytopenic purpura, for very, very long period of time. We diagnosed correctly. It was actually a Viscott-Aldrich syndrome, which also presents with thrombocytopenia. And both of them have similar HLA genes. So we got fully HLA matched international donor, and both of them were transplanted with the same stem cell donor stem cells, and both of them were cured with the transplant. This is the girl which I mentioned earlier, a double half match transplant for severe aplastic anemia. This was the eldest patient we did transplant, 71 years myeloma, and this is one of the renowned physicians from Latur, Maharashtra, who had a deadly AML. We did half match transplant at the age of 67 years. So now, apart from that, there are a lot of newer things we did. Half-mass transplant, one of the most advanced type called as T-cell deplete half-mass transplant, we have done first time in India in adult patients, almost close to 7 patients. And we were the first one to start prophylactic therapeutic white blood cell transfusions in India in a corporate setup way back in 2013. So, like the famous saying, every ending is really a just new beginning, and this is very apt for most of the hematological disorders. You can see globally the number of transplants are increasing annually, and the survival is also increasing. Even in India, the number of transplants are going high, and we have done more than 150 transplants at Yashoda Hospital, Somajiguda, with survival success rate of 82%, and with transplant-related mortality, which is a parameter of the experience of the transplant center, is less than 10% in most of the cases. Like the famous saying, coming together is beginning, keeping together is progress, working together is success. So this is all possible. All these 150 transplants is a teamwork. I'm the face of that team, but the team comprises of all the people working in our team: nurses, paramedical staff, housekeeping, my residents, my registrars, my subspecialty colleagues, and most importantly, the physicians and pediatricians who send them in timely manner, the early diagnosis, timely treatment, and then who continue to follow them. These patients are quite demanding. Vigilant and careful follow-up of these patients is very important for transplant cure. So each of us have strengths and limitations, and through togetherness we can succeed in these cases. So these are the number of transplants in India. You can see close to 2,000 to 2,500 transplants are done in India nowadays per year. Whereas even in my Telugu state alone, the number of new cases of blood cancer are about 40,000, of which almost 20 to 25% require bone marrow transplant. So going by these numbers, in both the Telugu states alone, the number of transplant requirement is 10,000. Whereas we togetherly in both the Telugu states do closely about 100 to 150 transplants. So there is a lot of scope and lot of demand and need for this specialty and for this specialist. Apart from that, we have a lot of international tourism patients approaching us for these high-end treatments like bone marrow transplants. So That's why the more and more transplants are performed because of the technological advances. The outcomes are getting better and better, and you can see about roughly 12.5% increment in the number of transplants globally. Normally, across the globe, currently about 70 to 80,000 transplants are done per year, right? So about allogenic transplant 40,000 per year, and they are increasing every year 12.5% per increment per year. That has, because of the advances in all the aspects of transplant, the outcome has also improved about 10% per year. So whether you end up becoming a hematologist, a physician, pediatrician, any clinician, you are going to get a lot of these transplant survivors under your follow, and that's why you need to know about transplant. I'm sure many of you in the audience will pursue hematology as your career and maybe a future transplanters. But apart from those practicing any aspect of medicine will end up caring for these transplant patients. So the mortality has gone down significantly. The mortality is less than 10-20% across different types of transplant, and these are the complications of transplant which you need to understand: opportunistic infections, graft versus host disease, and relapse. If you understand these complications, you will end up doing caring well for these patients. A lot of breakthroughs are coming, a lot of approvals, so the challenges are getting sorted out. So the future of medicine is very bright, particularly in the field of hematology. There's something called as chimeric antigen receptor therapy, kind of missile, guided missile, which selectively goes and kills the cancer cells. The concept, if you go through the concept and you understand the logic behind such newer treatments, it's very exciting and it's very, very interesting. Not only that, what I told you before, the T cell deplete half mass transplant, which we have done in our center, is a newer kind of advancement. So most of these advances are being practiced in majority of the advanced transplant centers. Suicide gene therapy. So, coming to the what I told you before, the CAR T cell therapy, I will strongly recommend a beautiful movie, Hollywood movie released in 2016, where Gerard Butler has acted in this movie, A Family Man. A wonderful movie narrating the story of CAR T cell therapy in relapsed refractory acute lymphoblastic leukemia in this child. So another important aspect of this movie is an Indian doctor was highlighted. Anupam Kher has played the role of an Indian doctor working in New York, one of the best cancer centers in United States of America. It's a very interesting story, and they have real-time, realistic enumeration of the journey of a blood cancer patient undergoing the most recent advanced treatments in this. So, coming to the advances, this was the picture. We have an Indo-China exchange program last year where about 9 hematologists from India were invited at Beijing, Peking's University Hospital, Beijing. And it was wonderful to see in one center. I mentioned you earlier, in our India, we do about 2,000 to 2,500 transplants per year. That is across the country. And this one center does more than 1,000 half mass transplants per year. Our neighboring countries in Southeast Asia are doing so well. It's high time, to take this challenge and join in hematology and start helping and accepting these challenges and getting newer advents in the hematology available in India. So before I conclude, I would like to say, this is a famous saying by Francis of Assisi: start by doing what is necessary, then you end up doing what is possible, and suddenly you realize you are doing impossible. And that's what every one of us is going to do in future. I'm sure all of you have a bright future ahead. Just decide the specialty which you are keen, which is your passion, and you will be doing wonders in the coming era. I had narrated the past, present, future of bone marrow transplant, but the specialty of hematology is very, very interesting, thrilling. If you go through the past, present, future of hematology, I'm sure many of you will pursue hematology as a career. And before I conclude, this is very important for all of us to not underestimate ourselves, realize our value. This is again way back in 17th century, a famous saying by the English physician James Townley about the charisma of us clinicians. It says, wonderful is the skill of a physician, For a rich man, he prescribes various admixtures and compounds by which the patient is brought to health in many days at a huge expense of 50 pounds, just 50 pounds during 17th century. While for a poor man, for the same disease, he gives a more common name and prescribes a dose of oil, which works wonders in terms of cure in a single night, charging 4 pence, which was even nothing even during that era. Such is the charisma of us clinicians. We have to believe ourselves and continue doing well. You end up doing miraculous things. So we all of us are going through this deadly pandemic, SARS-CoV-2 virus. On the left side, the photo, my electron micrographic photos, electron micro photograph of SARS-CoV-2 virus, a tiny zero point 0.1 microgram virus, which is nothing but a kind of genetic material wrapped in a lipid shell, which leads to devastating picture with such high mortality across society and has created havoc across the country. And such pandemic, this is a picture, one of my favorite from the 13th century. This is 1348 when the Black Plague pandemic was happening in Europe. And what you see here is a plague doctor wearing the special PPE during that era. And you can see special face mask, which is of the size of bird beak. Why bird beak? Because you can see hundreds of dead bodies hanging around, lying around this doctor. So the big part used to be stuffed with herbs and flowers to protect these doctors from the stanch smell of the dead bodies lying around. And also on his left hand, you see a stick to maintain social distance. The people, 8 centuries have passed by, and even today, the most important strategy for protection against the COVID-19, because the outcome is unpredictable and there is no definitive therapy. So prevention is better than cure. And what that plague doctors or our ancestors 8 centuries before have taught us still holds true, and there is not much of a remarkable improvement in managing such viral pandemic. And then still prevention stands the gold standard gold standard strategy for us. So prevention is better than cure. So it is not the strongest of the species that survives, not the most intelligent one, but the one who is most responsive to change. And it is, change is something which, if we continue to adopt, we are going to do well in our lives. So thank you so much for your attention, and I end here by appeal to keep safe and stay safe amidst this pandemic with appropriate use of the PPE kits and social distancing. Any of you have any questions you want to ask, you can ask here, or this is my mail ID. You are most welcome to connect if you have anything to discuss with regard to my talk. Thank you so much.
Thank you so much, sir. Would request Mr. Srimay Patil and Ms. Shreya Shah to start question and answer session.
Hello, good evening, sir.
Yeah,
first
good
of
evening.
all, on behalf of all the people attending this webinar, I would like to thank you for delivering such a phenomenal talk.
Thank you.
I'm sure everybody has been enlightened so well. So after listening to your talk, sir, many of us who intend to pursue a career in internal medicine might want to be hematologists. So
thank you.
I would like to ask you, what challenges do you face as a hematologist today in an Indian setup?
So, when I joined hematology, the number of super specialty, institutes offering super specialization in hematology were far less. When I joined, there were only 4 institutes: AIMS, CMC Vellore, and the Kolkata, Medical College, Kolkata. There was hematology in KEM Mumbai also, but that was MCI not recognized that time. Now it is recognized. So the institutes offering super specialization in hematology were less, but nowadays I think there are about 60 DMCs across the country. So it's a good specialty to join. It's somebody who is interested in diagnostic challenges and handling such patients with curative intent. This is the specialty for you. There are a lot of challenges, like of course, these challenges are also now getting resolved over a period of time. Initially, there were not many hospitals, corporate hospitals or government institutes providing adequate, appropriate infrastructure to practice hematology bone marrow transplant. But now that number is also slowly expanding. A lot of institutes are coming up offering hematology super specialization, and a lot of hospitals are coming up providing adequate infrastructure to practice this high-end specialty.
Yes, thank you so much, sir. I'm sure many people would like to take up hematology after listening to your talk today.
Thank you, Doctor.
So proceeding on to the next question, in India,
Yes.
we see that a large strata of people is unable to afford bone marrow transplant as a treatment modality for bone
Correct.
cancers or various diseases. So what do we have to offer to these patients?
So that's a very important practical question, Doctor. So as I mentioned you earlier in my slide, the number of eligible patients in this Telugu state alone, who are ideally treated with bone marrow transplant with the best possible cure rates, they exceed 10,000, and we are, how much we are doing about 100, 500, 100, 150. So that is not even 1% of what is required across, and that is true everywhere across the country. So one of the major barrier for transplant is the financial affordability. So because most of the patients from our country, they have to shell out money out of their pockets for their treatment. Insurance is not quite rampant across the society. That is one of the challenge, and those poor patients unfortunately end up succumbing to their diseases. So if we have something some kind of public institutes offering these treatments at a discounted cost, or wherever required free of cost, that may change the scenario, and that by that we might end up curing many of those deserving patients.
Okay, thank you, sir. Thank you, sir.
Sir, in the current COVID pandemic, what challenges are you facing in your practice, especially with regard to pre-op and post-op patients?
Yes. So most of the blood cancer patients, so in hematology, there are two sets of patients: blood cancer patients and benign hematological patients. So for blood cancer patients, blood cancers, most of acute leukemias are medical emergency, right? So for acute leukemias, whether it is pandemic or not, if we don't act, if we don't treat, if we don't intervene, they are going to die. So even if there is a threat and risk of COVID infection, you have to treat them. So, of course, when they acquire COVID infection, their mortality is more than 50%. So normal general public, the mortality is somewhere between 1 to 2 to 3%. But for hematological malignancies, it's more than 50%. But yes, there are certain hematological malignancies which are very aggressive that need to be treated. So we are treating them, admitting them, treating them as per the international guidelines. There are certain blood cancers like low-grade lymphoma, or the patient who is already treated and whose disease is under control. Those patients, we are switching them to teleconsults and asking them to continue whatever oral medications as much as possible. Whereas aggressive blood cancers needs to be treated. Again, coming to benign hematological conditions, there are certain benign hematological conditions which have serious implications. For example, ITP, right? If somebody's platelet is 10,000, 5,000, they need to be treated, right? So they need to come to hospital, and we need to assess and then treat. And we are treating them with the safest possible medications, and as and when required, depending on the circumstances, we are asking them to come to the hospital, and those which we can manage through teleconsultations, we are managing teleconsultation. Again, coming to bone marrow transplant, emergency bone marrow transplant. I had shown this girl. Even if this girl would have approached me now, despite COVID pandemic, if we would not treat her, she is going to die 100%. If we treat her, there is a possible potential risk of acquiring COVID and dying out of COVID, but that risk is not 100%, right?
Right.
So, emergency conditions we have to treat. Those where we can wait for next 2-3 months, we are asking them to stay home and continue oral medications till the pandemic is over.
Right. So, sir, as we have read, post-transplant patients are started on steroids for prevention of GVD.
Correct.
So, and then opportunistic infections are very likely in such cases if proper care is
Correct.
not taken.
Correct.
So, I guess fungal infections are more common than the viral infections.
Yeah, all infections are common, but fungal, because steroid associated, cellular and humoral immunity difference, impairment, the fungal infections are quite common. And as a rule, all the patients of GVHD who are on steroids, dose exceeding more than 0.5 milligram per kg, they are on antifungal azole prophylaxis, mostly voriconazole or posaconazole tablets. But what we are doing, this is a very important question, and many of you clinicians might be handling, monitoring, following up these patients. So what we do in this COVID pandemic, there are our country is one of the such a fantastic place where you can try a lot of newer things, keeping patient at the center of your focus, right? So there are a lot of newer molecules which are less immunosuppressive and which are best suited under this condition. So what we do, somebody has a GVHD, we try to start them on steroids. Steroids are the gold standard treatment, but we try to, once the GVHD is under control, we try to taper their steroid dose and get them on alternative immunosuppressive newer medicines which are less toxic, which don't require antifungal, antibiotic, antiviral prophylaxis, and which can reasonably control their GVHD, at least for the time being.
Okay. And sir, in the current situation, so do we need to administer antiviral prophylaxis also because of this?
So all the patients of hematological malignancies, mostly leukemias and bone marrow transplant patients, they are all patients after allogenic stem cell transplant, they are as a rule on antiviral and anti-PCP prophylaxis for at least 1 to 2 years post-transplant. So they are on oral penicillin prophylaxis, they are on antiviral prophylaxis, acyclovir, and they are on PCP prophylaxis with Septran. These three are integral on follow-up. And also they get vaccination. I had not mentioned because it's a vast topic. All patients completing transplant, they get vaccination just like a newborn child gets vaccination schedule. All our transplant patients get vaccination after successful transplant, 6 months to 1 year after transplant, to protect them from vaccine preventable infections, mostly viral infections.
Right. Thank you so much, sir.
So, proceeding to the next question, you mentioned umbilical cord blood collection as a treatment modality. So, what is your opinion on preservation of umbilical cord blood, and how far have we exploited the plasticity of stem cells in treating diseases?
So, that's a very important question. Umbilical cord blood transplant is one of the very, very demanding, complicated, complex transplant, right? So, when I was during my training at Canada, I had seen a lot of umbilical cord blood transplants. But nowadays, the number of umbilical cord blood transplants in our country has gone drastically down, right? So mostly umbilical cord blood transplants are useful for pediatric patients where the weight of the patient is less, because the major limiting factor for umbilical cord blood stem cells, they are immunologically naive and they take longer time to recover from the stem cells to blood, complete hematopoietic system development, and the stem cell dose is limiting, right? So that's why they are mostly used for pediatric population, and because it's a complex, demanding procedure, rather than umbilical cord blood transplant, most of the transplanters across the country, if there are no full match donor either in the family or international registries, we go to half match transplant, so which is easier. Half match family donor is always available, the cost of treatment is less, and outcomes are better than umbilical cord blood transplants.
Thank you,
sir. I would like to ask you about prenatal diagnostic testings, about which we recently read.
Correct.
So with the advent of these new machines like NGS, etc., these companies have come up with various diagnostic testings. So
Yes.
how prevalent are these testings amongst Indian population today, and like what is their future? Sorry.
Correct. So this is a very, very important question. Thank you, doctor, for bringing out this question for particularly the genetic or inherited disorders. Prenatal testing is of utmost importance, right? So by doing the prenatal test at the early pregnancy, we can diagnose whether the coming baby is carrying the same genetic defect and going to be the same diseased, afflicted baby. So if the genetic tests are positive, we terminate the pregnancy, we avoid this, the diseased babies. So prenatal testing is done. It's a common, literature knowledge you might have gone through in your textbooks. The NGS based either by the chorionic villus sampling or amniocentesis during first trimester pregnancy. These are at this point of time available at select tertiary care centers, right? It is not available widely across all the hospitals. So yes, they are available and they are being utilized across. The most important thing is literacy across the families having the history of genetic diseases. More so in Indian, culture. In our Indian culture, we have certain communities have consanguineous marriages where the incidence of these genetic diseases is high, and if there is an index case in these such families, prenatal testing is of utmost importance. For example, sickle cell disease, thalassemia can be completely prevented by timely prenatal genetic testing and avoiding these embryos to proceed further, leading to defective childs subsequently.
Right. Thank you, sir. And sir, one more question was that, like in the cases where we collect umbilical cord blood, are prenatal testings also done in those cases mandatorily?
So if this again a very important aspect. So the umbilical cord blood is collected with the precise family history. If that family has a history of possible such genetic diseases, umbilical cord blood is tested for the genetic diseases. But as such, as a whole, apart from the conventional, the normal screening tests for any blood product like viral screening and the various infectious screening, other than that, special tests are ordered only if there is an possible or already established genetic defective family member in those umbilical cord donation mother.
But sir, like we know, a few years back when first this technology came in India, it was the pricing was around 2 lakhs and more also. But now many companies have come up and we can see advertisements on television and everything.
Yes.
So those people are doing it quite cheaply. So many people are opting for it now.
I will like to put a very important message across on this platform. The umbilical cord blood collection for personal family use carries no meaning at all. That is not correct. And then there are position papers by American Society of Bone Marrow Transplant, European Bone Marrow Transplant Organization. Umbilical cord blood has value only if it is collected through a public cord blood banking. It doesn't carry any importance if it is collected for our own family utilization. And then all these private blood banks, cord blood banks, they just capitalize on our emotions, right? And then they ask, secure your future child by collecting the umbilical cord blood stem cells. The possibility or the probability of utilization of that cord blood in that family is very, very meager. So, in Western countries like Eurocord or New York cord blood bank, which is actually government has undertaken this cord blood banking, and as a routine, these cord blood samples, the cord blood bags are collected from most of the hospitals and they are stored just like our blood bank, right? So blood bank has all blood group, blood products, platelets, FFPs, and whenever somebody is in dire need, that is issued to that particular person. So the cord blood banking undertaken by the government or public private partnership has value. Individual cord blood banking doesn't carry any sense.
Okay, so that is a very important statement you have made actually, because normal people are usually not aware of these things, because we see
Correct.
advertisements on television and
Yes.
they are
That
like
is
provoking
that
people
is
somewhere.
that is a business propaganda, and that is not recommended across the globe.
Right, so that
Thank
message
you,
should be
sir.
actually propagated.
Yes.
And sir,
Okay, sir.
like I said, just a second. So like I said, in this cord blood collection, see, now they are doing it on a commercial scale. So if they are not having prenatal diagnostic testing done, they can also take blood from a patient who is actually a case of genetic disorder, and then that
Correct.
blood is anyway going to be useless.
Correct. That's what. So that is the very reason I told categorically the probability or the possibility of this cord blood bank, the cord blood unit collected for family use is extremely meager. Right? It has to be collected from healthy families and has to be used for public cord blood banking. Then only it has a value. And nowadays, I told you, in my recent, our Indian delegate visit to China, they are doing half match bone marrow transplants in not hundreds, thousands. In India, the half match transplants per year are not even 500 over the year. Whereas in one center in China, Beijing, the Peking University Hospital, the number of half-mass transplants exceeds thousands. So you can imagine, half-mass transplant is the future for a country like us. Even the international donor transplant, it involves a lot of cost. And now with the advent of medicine, the results of half-mass transplants are matching up with full-match bone marrow transplants. So half-match transplant is economical, readily available, and a very feasible option for our patients in our country. And I see the future is going to be, with regard to half-match transplant, the numbers are going to explode in very near future in our country. Yeah.
Sir, just for the clarity, I'm asking this question, that half-match transplant means out of those 6, 3 or 4?
No, so normally we carry, so that depends, high resolution, low resolution HLA typing. If it is low resolution, we count only 6. ABC. If it is high resolution, ABC, DP, DQ, DI. Class 1 and class 2 HLA genes, right? So if it is high resolution, 10 or 12. So out of 10 or 12, less than, so one antigen mismatch is not half match, but the results are as bad as half match. So half match doesn't mean exactly half, 5 out of 10, it can be 5 to 8 out of 10. That is all half match. Results are equal. Whereas for 12, if you are counting 12, so between 6 to 10, everything is half match. And full match is 6 by 6, 10 by 10, 12 by 12. Yes.
Okay, thank you so much.
Thank you, sir. So another question we have in the Q&A tab is, what is the nutritional intervention in bone marrow transplant, and what is the role of glutamine in bone marrow transplant?
Yeah, this is another very important question, doctor. So, as we discussed during bone marrow transplant, these patients are given extremely high doses of bone marrow destroying chemotherapy or chemo plus radiotherapy together. So this, apart from destroying the marrow, the other important aspect of this chemotherapy, they cause severe mucositis. The whole gut is denuded, right? So many times, majority of the times, these patients are not able to maintain their oral intake. So then we start them on total parenteral nutrition during transplant. And yes, glutamine is an important aspect. So reduced glutathione, glutamine, because many of the chemotherapies are organ toxic, hepatotoxic. So, adding glutamine, reduced glutathione, they helps in, these antioxidants help in decreasing the incidence of hepatotoxicity.
Thank you, sir.
Thank you.
Sir, in a research paper I recently came across, in a study for AML, it was found that autologous as well as allogenic HSCT has leukemia-free period more than conventional chemotherapy, but the overall survival rate of that patient was not improving, or of that sample space.
No,
due to
doctor,
transplant-related complications.
yeah, I'm sorry. Can you please repeat the question? I'm sorry, I missed the first part of your question.
Sure, sir, no problem.
Huh.
In a study of AML patients,
Yes.
it was found that autologous as well as allogenic HSCT had better leukemia-free period than conventional chemotherapy. Right.
Yes.
There is a bit to it.
Yes.
But the overall improvement in survival was not there because of transplant-related complications.
Correct.
So how do we deal in such cases? Like, what call do we take, or how do we assess the risk-benefit ratio?
So that's again a very important question. So, the bone marrow transplant outcomes are, as I mentioned earlier, they are improving year by year. Every year there is improvement in the outcomes with our experience, with our that learning curve is continuous. So the outcomes of transplants are improving drastically. So for many diseases, the median age of onset is older people. It's like AML is disease of elderly. The median age of AML diagnosis is 60 to 65 years, right?
65.
So these patients already have comorbidities. These patients are advanced age. Their tolerance, their ability to tolerate chemotherapy will be less. So they will have more, transplant-related morbidity as well as mortality. So what we do, we devise protocol in such a way. There is something called as, myeloablative chemotherapy, reduced intensity chemotherapy, as well as non-myeloablative chemotherapy. And there is a new concept, reduced toxicity, newer drugs, for example, busulfan. There is triosulfan, which is far less toxic than busulfan, but which is equally effective as busulfan, right? So, there are ways to devise your protocol to handle such high-risk patients where decrease the transplant related complications, mortality, morbidity, at the same time increase the survival with early intervention with bone marrow transplant. So there are ways to it, but there are certain circumstances. So, as a rule, any bone marrow transplant patient, whether it is autologous transplant, allogenic transplant, we do pre-bone marrow transplant workup. That person's all organ system, the organ function reserve is assessed. Heart, kidney, liver, lung, everything. So those who are having very bad heart, very bad lung, they are not taken up for transplant because the chances of them dying during transplant is very high, right? So there is something called as, various models, hematopoietic stem cell transplant comorbidity index. And based on that HCTCI, we decide whether this patient is appropriate for transplant or not. There are some patients who their risk of dying from transplant is much higher than the benefit obtained out of transplant. So as a clinician, we always balance the risk-benefit ratio, right? So if the risk-benefit ratio is in favor of transplant, we offer transplant. If somebody is very, very, has a very bad organ functions, we defer transplant.
Right. So ultimately, we have to individualize the treatment for every case.
Correct.
Right. Thank you, sir.
Thank you, sir.
I guess,
sir,
yes.
just last question.
Yes.
You mentioned bone marrow registry in your talk.
Yes.
So I guess they have started one in India also.
Yes.
So how successful has it been, or how helpful is it in acquiring marrow for people?
That is one of the myths. We don't acquire bone marrow from the donors. What donor have to do? They just have to get the HLA gene testing. And in India, we have a couple of bone marrow or stem cell, hematopoietic stem cell registries which are available, wherein that they do donor drives and donors gene test, HLA testing is done, and it is fed on the database. And somebody who requires the stem cells, again the registry contacts the donor, asks them, are you willing to donate stem cells? Because we don't collect bone marrow most of the time, but we collect stem cells just like platelet collection, which is not risky to donors at all. But yes, donor has to take 5 days of GCSF or as a subcutaneous injection or abdomen to mobilize stem cells from the bone marrow to blood. So in India, we have more than 1,000 bone marrow transplant done from Indian registries, and that proportion, as the people awareness is increasing, a lot of donors are coming forward to donate stem cells, willing to donate stem cells, get them tested, and willing to have their name registered with the registry. And whenever there is a requirement, It is kind of, you have to understand one very important thing. I want to deliver a very important message on this platform. To donate organs, you can donate organs only when you are dead. You can donate, that's called as organ donation. Lot of organ donation campaign is happening, right? Here, being alive, having no risk, you can save somebody's life by donating your stem cells.
Right, sir. So basically, all of us must go to that registry and get ourselves registered and
tested, and we should, express our willingness to save somebody's life with if our stem cells, if we are lucky to have our stem cells matched with some needy patient, some needy blood cancer patient, some needy, thalassemia, sickle cell anemia, inherited marrow failure disorder, primary immune deficiency disorder patient. Our stem cells can completely give a new life, new birth to somebody in the society. And that we can do it when we are alive without any risk to ourselves.
Right. So that is one important thing. Like most people, including medical students like us also, don't have this clue about this registry.
Yes.
Like we know about blood donation, but we don't know about stem cell donation and this registry. So that is a important thing. And sir, the word you mentioned about peripheral stem cell banking.
Yes.
So what is that exactly? Like we can donate for ourselves or store for ourselves?
It is like it's not peripheral blood stem cell banking. What they do, they can collect the blood and get the gene testing on the blood, and that gene testing report is put on their database. And the gene testing even can be done from oral swabs. Buccal mucosa contains the same genes which our body has. So HLA gene testing can be done from buccal swabs without actually any blood testing. Painful, a lot of donors are, hesitant or fearful of getting simple blood drawn and blood testing. So for them, even buccal mucosal swab, just like brushing, you collect the buccal mucosal swab, deposit to the registry. They will get the gene testing and maintain your HLA genotype in their database.
Right. And so, sir, if like I want to store my own stem cells today, if I am fearful of, or if I am a carrier of any genetic disease, like which is not manifesting in me right now, but if I want to be safer, to be on the safer side in future, so is there any modality for that?
Absolutely no. Many diseases have their origin years, decades before they manifest. So your own autologous stem cells, and then you have to understand the autologous stem cell collection, number one, and storage is very stringent, very, very demanding, and very costly, very expensive, right? So that stem cells have to be stored in liquid nitrogen for, unpredictable, indefinite time. It's very costly. And, as I mentioned earlier, this year, European Hematology Association, there was a breakthrough paper, right? So one of the paper, research done by the Spanish people, they have shown that a simple blood cancer like acute lymphoblastic leukemia, 1 out of 20 children are born with acute lymphoblastic leukemia cells at birth. 1 out of 20. But out of them, that means 1 out of 20 means almost 5% normal children have that potential to develop blood cancer subsequently in life. But out of that, very unfortunate, rare children subsequently go on to develop blood cancer because that is called as first hit. They have genetic inherited defect, that is first hit.
Right.
They need second hit to develop that genetically predisposed clone into actual blood cancer. So that second hit can be environmental, can be anything. But few of them develop. So, that is called as clonal hematopoiesis of undetermined significance, CHIP. Right? So CHIP is there for, and then we still don't know 100% what are defects we are born with, right? So every year research is happening, every year new things are coming out. So there is, at this point of time, it doesn't carry any sense of collecting our stem cells and storing for, potential future use.
Right. Thank you so much, sir.
Thank you, sir.
So I guess that is all with the Q&A session.
Yeah, thank you so much.
Thank you.
Yeah, I think we'll hand over to Shikha Gupta ji for concluding the session.
Thank you so much, sir. So we from GetWell would like to extend our gratitude to Doctor for taking his valuable time and sharing this information with everyone attending this webinar. A special mention to Mr. Srimay Patel and Ms. Shreya Shah for coordinating with us before and during the webinar. Also, heartfelt thanks to all the attendees for joining the webinar and making it an awesome session. With best wishes from GetWell family, I request everyone to take their leave and have a nice day ahead.
Yeah, thank you so much,
Thank
GetWell,
you, sir.
for bringing us together on this platform, and thank you so much all the students from Dr. VM Medical College. It was a wonderful interaction discussion, and I'm really amazed of the by the the knowledge and their curiosity. I hope we could have been like this during our MBBS days, and I hope and I wish all of them a bright future and a very brilliant career ahead. Thank you so much. Stay safe, stay healthy, and bye to everyone. Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir. Thank you.